So I have the honor today of introducing Dr. Scott. She has done some awesome medical anthropology work down in Veracruz in Mexico, and she's also helping us start the Las Cruces Rural Track program. She's not one for much formal introductions, but I would like to turn it over to her right after I have a plug that if any of you guys want to work down in Las Cruces, please reach out to her directly, especially if you want to be assistant program director. Dr. Scott, the floor is yours.
Thank you. And thanks for that plug for the Rural Track program in Las Cruces. We're really excited about getting that up and running very soon. So I am going to share my screen. I'm going to try to, let's see. Oops. Yeah. There we go. You all are seeing halfway through my presentation, I think. Are you all seeing the presenter view or just the slides?
We're seeing the presenter view.
Okay. Now, are you seeing the slides?
Yes.
Okay, perfect. All right, so thanks for the introduction, Dr. Mishra. I really appreciate it. I think I know some folks who are on this grand rounds, but if I don't know you, I am a medical anthropologist. I recently became the permanent executive director for the New Mexico Primary Care Training Consortium, and that is part of what we're doing with that consortium is working with UNM to develop this rural track in Las Cruces. And I'm also a college professor in the College of Arts and Sciences at New Mexico State University, which is where I have started my career in medical anthropology. So I'm going to talk with you all today about first, I'm going to provide a lot of context, but ultimately we're going to get to a study that I participated in with a number of colleagues on diabetes management and mental health during COVID-19 in rural southern New Mexico. So I'm going to contextualize this in the context of medical anthropology for you all first, and hopefully offer some tools and some frameworks that might be helpful for you in your work as well. And I also will say I'm happy if people have a question during the presentation. I'm happy to answer questions in the middle of the presentation, but if you don't mind just using the raise hand function so that you'll pop up to the top of my screen so that I'll actually see you, because I'm gonna have a hard time probably seeing the chat. So if you'll just raise your hand, that would be really helpful for me. And then we'll also have time for questions at the end. So I don't have anything to disclose for this presentation. I also, before I get started, because it's really important, I think, to acknowledge all of the people who have participated in the work that I'm going to present today. Dr. Catherine Olsway, who is an associate professor of anthropology at NMSU, and she was actually the PI for this diabetes management study that I'm going to be talking about today. I had asked if she could join me today, but she was unavailable and gave me the go-ahead to present without her. But she's a biological anthropologist who I work really closely with. And we also had several students who worked with us on this project. So I just want to name them so that they can be acknowledged as well. Haley Taylor, who's a graduate student in anthropology at NMSU. Andrea Marañón Laguna, Emily Montoya, and Elisa Garcia, who were all undergraduate students at NMSU at the time that we did this study. And then Claudia Mares, who works with Doña Ana County Department of Health and Human Services and really facilitated our ability to do this project. So major thanks to them for their work on this as well. So what we're going to talk about today, one, is that I hope that by the end of the presentation, you all will have a little bit better understanding. If you don't already, there may be some medical anthropologists on the meeting, or people familiar with it. But if you aren't already familiar with medical anthropological approaches to mental health, I hope you will gain a little bit more understanding of that. And then second, and I'm sorry, I'm seeing that there's a chat, but I actually can't see the chat. So if somebody has something just unmute and let me know. The second objective is to apply culturally and structurally sensitive perspectives to mental health concerns. And then finally, identify key mental health factors within that context of culturally and structurally sensitive perspectives in diabetes management during a pandemic, which is the specific study that I'm going to be talking about. Okay, there we go. So I'm going to briefly mention just 5 types of approaches that I have used in collaboration with colleagues in order to understand both mental health concerns, but also physical health concerns among the people who I work with in my research. And so one area is anthropology of policy. So really what we are doing from that framework is looking at how anthropological work can inform policymakers and help to design policy that supports interventions that address the needs of our multiple constituencies who are working within research. And in terms of mental health, we're really thinking obviously about both current policy that may negatively affect people with mental health concerns or those who support them, as well as really thinking proactively about what policies may need to be developed and constructed in order to better support all of those groups of people. We also are thinking from this perspective about stigma, discrimination, and dehumanization of people who have mental health concerns, and particularly certain mental health concerns that get more stigmatized than others, and as well as the human rights of people with mental health concerns, so that we can really think about how we can develop policy that better supports those human rights, as well as reduces stigma and discrimination. Intervention design from this perspective is often interdisciplinary, and we're often doing that work in collaboration with psychologists and psychiatrists. And so we'll talk a little bit about that, I hope, in the discussion today. The 3 areas that are more the focus of this research that I'm going to talk about a little bit more today are these 3 in the middle. So one is the anthropology of health systems. We're really looking there at how health systems are embedded within larger social and economic systems that are all impacting mental health and mental health care. And so for example, we might be looking at differences across different health systems, as well as similarities across those systems, and how the larger social and economic systems are impacting the healthcare systems that we're working within. And then the third area is anthropology of healing systems, which is a little bit different. So when we talk about health systems, we're really talking about the institutions, right? Hospitals, clinics, other places that provide healthcare services, and how those are interconnected or not interconnected, maybe when they should be. But in healing systems, we're really talking about the social and cultural context of health and illness, and what health and illness mean for different communities, different populations, whether those are geographic populations or culturally diverse populations. And so we're really looking at how do people label health and illness and different types of health and illness experiences that they have. How do people express what it feels like to have that illness, or what it feels like to be healthy? There's a specific area of ethnopsychiatry that is not really my area of specialization, but you may have heard of that kind of falls within this category of the different approaches. And so we're really looking at analyzing the different ways that people understand illness and disease, as well as health, and really trying to look at those concepts from the perspective of the people who are experiencing them, rather than necessarily from an outside perspective. And then in terms of experiential anthropology, this is where we really are focusing in on really exploring the daily lives of people who have mental health concerns, understanding how that can be connected to broader suffering that may be happening in a community, where you may see patterns of suffering within a particular population that are common across many individuals within that population. And more recently, really thinking also about the lived experiences and day-to-day experiences of people who are taking care of folks with mental health concerns. And so we look at many different components of people's daily lives within this context. So some really common areas that people focus on are medication regimens, interactions with healthcare systems, how people interpret what's happening in their minds or in their bodies, given their particular social and cultural context, as well as chronic illness and disease, and really looking at the life course of illness and disease and how that changes over the course of someone's life. And then the last approach that I'm not going to talk quite as much about today, but is certainly something we can follow up on in the future if anyone is interested, is the biosocial or biocultural approach, where we're really looking at the intersections of biology and social and cultural context. And so really thinking about how our environments, social, cultural, physical environments, can impact our biology. So the different ways that biological manifestations of disease sort of show up within those different environmental contexts. So that's the broad frameworks that we're working within. And I'll just take a second just in case anyone has any questions that you want to ask before I move into something a little more specific. Okay. And we'll keep going. Okay, so one of the areas that I have really focused on for a long time in my research is really thinking about how do we deal with the idea that people, or the fact, I guess, that people are coming from different cultural contexts when they approach or integrate or seek help from healthcare systems. How do providers really how can we deal with that, right, as providers? And so I'm sure you all are all familiar with cultural competency models. They've been around for a long time, at least probably 30 years or more. There have been a lot of critiques of cultural competency models, but this term cultural competency still comes up a lot. So I think it's still important to really think about where those models came from and kind of how they've changed over time, and some new directions that a lot of people are thinking about within this field. So cultural competence really became a buzzword like within the last 20 to 30 years. And like I said, it kind of continues to sort of be around. Early cultural competency models really focused very specifically on racial ethnic groups and immigrant groups. So for example, thinking about Hispanics and Latinos or African Americans or Hmong immigrants or Somali refugees, right? Those are the types of populations that were really being considered in cultural competency models. And the early idea was that if you could learn a little bit about the traditional beliefs and practices of people in these groups, then you would be able to communicate better, you'd be able to provide better patient care, and you'd be able to increase patient compliance or adherence to treatment. And the result of those often, well, first, the way that often got taught is that there would be didactics that would focus on teaching the characteristics of these groups or the cultural characteristics of these groups, and then practice with standardized patients who demonstrated that cultural group in some way through the way that they are acting and through their behavior. And so they're demonstrating what is kind of assumed to be standard, right? It's a standardized patient about this cultural group or population. Unfortunately, what has been learned about this is that most of the results of these kinds of trainings do show increased self-reflection in trainees, which is great, right? The increased self-reflection is definitely good, but there's really not been any clear data showing that there's a positive effect on health outcomes for patients who after trainees go through cultural competency training. And so why might that be? And you all probably already know. So I'll go through some of the examples. So like I said, I think it does make sense that there wouldn't be a positive impact on health outcomes. One, because it's just not feasible to be competent in others' cultures, right? Cultures are complex. There are many nuances, and there are also many cultural contexts that people are coming from. And so it's really impossible to become competent in other people's cultures. But also cultures are fluid, right? And I'm sure you all know this. Because you can probably think about it for yourself, that the boundaries are fluid. Individual people may or may not subscribe to some of the typical values and beliefs, and they may not subscribe to others. People come from more than one cultural background, and so they may be drawing on multiple cultural backgrounds in terms of their understanding of their health or illness. And people may draw on cultural contexts that they didn't necessarily grow up in, but have been exposed to or become integrated into later in their lives. And it's also possible, and people do this all the time, to be medically plural in their thinking. And so what that really means is that you're just able to hold more than one concept of health and illness in your head at one time. So people may be doing that, right? And finally, the last piece that's really important to think about is that a focus on culture can sometimes obscure other barriers to access to care. So often in the cultural competency models, what you would see is that culture becomes a barrier to care. And so you have to understand the culture in order to negotiate and navigate around that culture to get patients to adhere to treatments that you're prescribing. But there may be other barriers to treatment adherence that also need to be considered that might be obscured if you're focusing solely on culture. So one advancement, I'm going to check my time real quick. Okay. So one advancement that we had that was developed sort of to address some of those concerns with cultural competency is a focus on cultural humility, which again, I'm sure that many of you are familiar with this. So these newer models of cultural humility really emphasize the need for providers to recognize that their patients have cultures and that these cultures may play an important part in a role in their understandings of the world. In addition, providers all have culture that also may play a role in the way that you interact with patients and in the way that you provide medical care. And so the idea is just to be humble, right? To recognize that culture is valuable, but you don't necessarily know how people are drawing on or using or understanding their own cultural context. And so the idea is to be sensitive and responsive to people's perspectives and worldviews, and rather than making assumptions, to ask, right? Which seems pretty simple. So the idea is just that, we just recognize that providers just don't know all there is to know, either about their own cultures or those of their patients, right? We're always learning. And so you want to have that consistent self-reflection and allow for self-critique of your actions or perspectives that might lead you to stereotype or essentialize culture, and to engage in that kind of lifelong learning. So there's an anthropologist and psychiatrist, Arthur Kleinman, who you all may be familiar with, who's been around for a very long time in the medical anthropology world. And he developed a series of questions that he calls a clinical ethnography. And this is just an example of how cultural humility can sometimes play out in a clinical setting. And I won't go through all of these specific questions, but for example, what do you think this problem does inside your body? How does it affect you, right? And just trying to elicit those kinds of things from a patient rather than assuming that you already know because you have some prior knowledge of a culture that that person also considers themselves to be part of. But beyond cultural humility, again, one of the limitations of cultural humility is that it only focuses on culture when there may be other things going on that also are important to address. And so I know that some folks on this Zoom are familiar with structural competency, because I think I may have had some communication with some folks about this framework. But so I'll remind people who are already familiar with it, and maybe those of you who aren't can learn a little bit about this. But the idea of structural competency or structural sensitivity and competency is that there's more than culture, right? There's economic issues. There are so other different kinds of social barriers. There are political concerns. There are infrastructural concerns, within the context of the health system. And all of those are also really important to bring into the room when you're thinking about working with patients and patient-provider relationships. And so this is a theoretical framework that really promotes more institutional level interventions by clinical practitioners to improve patient and community health. And really the motivation is to try to disentangle culture from health disparities that are due to other factors, right? It's not that culture doesn't play a role, it's just not the only thing. And so we don't want to confuse those two, because there may be approaches that are different depending on where that health disparity is really coming from. And so what we focus on in structural competency is really encouraging health professionals to identify upstream factors that are related to patient health outcomes. So upstream meaning beyond just the individual behavior of that person, but those broader contexts that might be influencing what's happening. And then providing a framework to conceptualize patients within those contexts. And so also just as a note, right, there's a little bit of a problem too with the idea of structural competency, because similar to cultural competency, like we can't really know everything that there is to know about all the complex contexts that people are coming from. So we need to have a little bit of humility there too, and recognizing that you might know some of what is relevant structurally, in terms of economic issues or historical trauma or other kinds of issues that are sort of come from those broader contexts, but you might not know everything, even if you've had structural competency training. So again, that humility to engage in continual learning and asking questions and building relationships so that you can learn how these factors show up in people's lives. And so we're focusing on cautioning, again, against making assumptions and encouraging collaboration. So I'll pause there to see if anyone has any questions about what I presented so far, but that's really the context for me for the study that I did in rural southern New Mexico. I was really trying to think from that kind of a framework in terms of how we understood the data and what we might be able to do with the data that we collected and analyzed as part of this study. But does anybody have any quick questions? And like I said, I'm unable to see the chat, so if you could just raise your hand or say something. All right, Harrison, do you have a question, or is this just a thumbs up that we're good?
Just saying all good.
All right, thank you. All right, I will keep going. So the study that I worked on with my colleagues, who I mentioned at the beginning of this presentation, took place in rural southern New Mexico in communities that are identified as colonias. I'm assuming that many of you are familiar with colonias, but I often find that even when we're familiar with them, sometimes we haven't learned the details. So I want to give you just a few details about colonias. In the southern part of Doñana, or in Doñana County, in all of Doñana County. So as you may know, that colonias are defined by the United States Department of Housing and Urban Development. They must be geographically located in the official border region as defined by the La Paz Agreement. So it's 100 kilometers north and south of the border. They must be considered rural, so they have to meet a rural designation, a federally designated designation of rural. And they also must lack access to adequate water, sewer, decent housing, or a combination of those to be defined as colonias by HUD. A lot of common characteristics in colonias communities are their mixed status families in terms of immigration status. The communities are often, almost always, actually unincorporated, so they have no local government. The county government is the most local government that they would have. There's no city or town government. There often is a high percentage of manufactured homes, which you all may be familiar. Manufactured homes actually decrease in value instead of increase in value, and also require pretty expensive repairs fairly regularly. So they're hard to kind of maintain. There's a high percentage of Spanish speakers. There's often a lack of healthcare facilities, grocery stores, and other resources. Some colonias have some of these services. Smaller ones often do not. There are limited or no paved roads, limited public services, and often no flood control or protection, which is a real issue in Doña Ana County. It doesn't rain much, but when it does, it can cause a lot of damage. So in New Mexico, there are 150 identified colonias, and there are two types. There are entire communities, and then there are subdivisions of communities. Many of these colonias were created through loopholes in laws that allowed property owners to subdivide their land without following the subdivision laws, and that's what really led to this lack of access to water and sewage and other kinds of utilities and infrastructure in the communities. So in Doña Ana County, which is where I did my research, there are 38 designated colonias. About half of our county's population lives in colonias. There are 144 miles of unpaved roads in these 38 colonias, and only half of those are maintained by the county. So it's a little bit can be a little bit difficult to travel, to get around in these communities. And this is just a map of all of the colonias in Doña Ana County. You can see that they're kind of concentrated along I-10, I-25, just going from the south to the north of the county, and also along Highway 70 to the east and west. So the study that I'm going to talk a little bit about, and then I'm going to ask you all to engage in some discussion around this study thinking about that structural competency framework. So this was a mixed method study. We did surveys and interviews. The inclusion criteria for this study was that a participant needed to be an adult, so 18 years of age or older, with a diagnosis of type 2 diabetes, and they had to live in one of those 38 colonias in Doña Ana County. So we did 77 surveys with our participants. We did 9 individual interviews. And then after we analyzed the results, we went back to 2 of the communities and had focus groups to present those results in the communities, and then got feedback on the results that we presented so that people could add nuance to the results, let us know if they thought we were wrong, which people did. And I can tell you a little bit about that in the question and answer if you want to hear some more about that, and let us know what really resonated with them about what we had found in our study. So I'm going to focus on the qualitative component of the study today. I do want to say one thing that I think is important for this particular group to know is that in the quantitative results of the survey, there was a statistically significant association between psychological distress and poor diabetes management, which you probably would expect. But we did see that in the surveys. I'm going to focus on the qualitative piece, which was part of that was to look at why that association might have been there. So this is the map that we, the model that we created overall from all of the interviews that we conducted, as well as the survey data. And so it shows the conjunction of diabetes and COVID-19 in the middle, and then over on to the left are the factors that contributed to an increase in blood sugar and A1C. And then on the right are the factors that contributed to people's ability to maintain control of their diabetes. So poor diabetes management or ineffective diabetes management and more effective diabetes management on the right. So I'm going to focus in on the mental health component of this. So this is the left side of the graph. And so what I want to focus on is this top line. And so what we saw in our study, sorry, I'm going to try to move. There we go. Is that one, people had a lot of fear of getting COVID-19. And because there was a lot of fear around COVID-19, people would tend to isolate themselves or because family members were afraid of someone getting COVID-19, family members would often isolate that person. Often it wasn't if it was someone who was older, but just having the diagnosis of diabetes led some family members to be really concerned about that. And that isolation really led to a lot of mental and psychological distress for people as they expressed it themselves, which often led to eating foods that were not recommended and then led to an increase in their blood sugars or their A1C. There were also issues with exercise classes being canceled, so people were unable to continue exercising, which also had an impact on their blood sugars and A1C. And that did have a psychological component as well, which I'll talk a little bit about. So I just want to share with you a few quotes from our participants to give you a sense of what people were talking about and how we came to develop this, this model. Most of our participants I did identify mental health and sociostructural issues as key reasons that they were unable to maintain control of their diabetes. But I do want to point out that they typically did not tell us that they had any issues related to their ability to access medication or to see their primary care providers. So those did not turn out to be issues. It was really more, the mental health issues were actually a bigger concern for people. So I'll just read just a few quotes so you get a sense of what people were talking about. So one of our participants said, "One thing is I love to eat. What can I say? I love cookies and I love ice cream, and those are my two biggest downfalls. And I just didn't succeed. If I get depressed, I eat. And during COVID, I wasn't allowed out of the house for a while. My kids said, no, you don't, if you need anything, you let us know. But because I was older, they didn't want me out and about. So they sort of made me shelter in place. And that was very hard, I will say. And that didn't help my eating situation. But the hard part is like cabin fever. You just, because you can't go out, you want to go out more than normal. So I couldn't get out of the house and I wanted to go. So that did not help my anxiety or my depression at all. And like I said, when I get depressed, I eat." Another participant talked about their difficulties with exercise and how that related to mental health. And so she said, "I loved my water aerobics." And I'm sure that helped. I tried to get in there and kind of be vigorous as much as I can, as much as my body allowed me to exercise in the pool. And once that shut down, I don't know what, there wasn't much, no venue that I knew of to go exercise. So I know that you can go and walk and stuff, but I had some back problems, so I couldn't really walk at the park. COVID really impacted that part and a little bit of my mental health because I was just so disappointed and I was upset that, I just couldn't go out. And I'll read two more. So one from another participant that was also more related to exercise. And she said, "The only thing that really affected me was that I really enjoyed martial arts. I couldn't go to my dojo, and that was tragic for me. I lost the opportunity to get another belt in my preferred martial art. It was also because it's like a social event too. I guess 'cause it's similar-minded people and, it's stress relieving." And she went on to say later in the interview how much she felt that her stress had increased during COVID-19. And then the last person said, "I only have one daughter. She comes every day. She asks, 'How are you doing?' And I say, 'I'm a little depressed because of this virus and the diabetes. Sometimes I'm afraid to go out because I'll ruin my body.'" And she's referring to her fear of getting COVID and ruining her body because she got the virus. And then she said, "Because you got to take care of it, You have to watch what you do, what you eat, and it's hard for me. I get so depressed." And I think this is probably to be expected, and I'm sure things that you all have heard plenty of times about people's experiences with COVID-19, particularly when they may also be dealing with a chronic illness, and then the related mental health issues that come along with that. But I think I want to really think about this in the context of the place that people are living, right, in these colonias communities, and how that might, how that nuance may be different for them. And we'll talk about that in just a minute in the discussion. But I'm going to move on to the positive side. So this is the right side of our map. And so what you can see here is that when people had social support and a positive relationship, I'm at the very kind of the bottom left of the map, there were some follow-on activities that could happen as a result of that, that allowed people to maintain better control of their diabetes. So for example, people buying groceries for them led to their ability to maintain a healthy diet and then to be able to maintain their diabetes control, positive relationship with their primary care provider, led to reassurance that their diabetes would be well managed. And so they felt more comfortable, and that lowered their stress, which meant they were able to maintain control. Because there was an option for telehealth, people were able to maintain their behavioral health appointments, which helped them to manage the mental and psychological distress that was resulting for them due to COVID, which actually which led to their ability to maintain diabetes control, as well as to maintain a healthy diet, because they felt that they had the support, and they weren't sort of using food as a way to relieve stress, because they had other ways to relieve stress. So I'll read you just three quotes from our participants that kind of help understand this a little bit better. So one person said, "I have a behavioral health therapist, so we do it by Zoom. She sees me, I see her on my iPad, and it's always been on time and no problems. We're able to talk about all our issues in our sessions." And this person went on to talk about how, because she knew that she had that regular appointment with her behavioral health therapist, that she felt less stress and anxiety and was really able to focus on what she needed to do to maintain control of her diabetes, even in the context of the pandemic. Another person said, "I had the right food to eat and I could just go outside and walk. And I really had no stress, like relatives getting sick or us getting sick. And I had no stress like other people have. You know what I mean? And I don't stress myself out like thinking about the things that I can't do anything about." And so this person was actually really unique in that most of the people that we talked with had multiple family members who had really severe experiences with COVID-19. And she did not, and so felt that that really allowed her to stay healthy herself. And then the last one is just an acknowledgement of the social support that people felt that they had. And so this participant said, "My son helped me. He'd go buy my groceries and do my shopping for me and everything else. Anything, if I needed anything, I'd just call him and he'd go get it." And this person also talked about how they really struggled with anxiety throughout their life. But he was worried with COVID-19 that was really going to cause additional problems. But because he had that social support from his son, he was able to manage that and therefore also maintain his diabetes control. So that's just a few examples of the kinds of things that we were seeing in our study. And I wanted to see if we could possibly have, I know that's a lot of people on, but hopefully we can have a little bit of a discussion to just think about how you might think about connecting what was happening for these people in trying to deal with both controlling their diabetes as what in the context of COVID-19, and also trying to deal with everything else that was going on with COVID-19 in the context of the colonias, right? In the context of the place that they were living, and in potentially the different cultural contexts that they might be living in. So I hope someone will be brave enough to jump in. Are there any, and you don't have to answer these questions in order, but is there anything that came up for you when I was either explaining the colonias or talking about these participants' experiences that bring to mind any cultural or structural factors that might be at play here that may be important in better understanding, even beyond what I just told you about their experiences, in terms of better understanding the context of their experiences?
Yeah, I have a question. Perhaps,
Sure.
as you mentioned, the extreme ruralness, or rather ad hoc nature of some of the founding of these communities has led to, under-resourced and difficulties obtaining resources. What about like phone, internet connectivity? Things that became even more important during COVID in terms of virtual visits, etc. Um, was that a factor as well?
Yeah, that's a really good point. So I think I did point out that people who were able to use telehealth, that was very helpful, right? And that really was one of the major factors in terms of people being able to maintain control of diabetes. Being able to have those behavioral health appointments through telehealth was really critical for people. But yes, in the colonias, there is real concern with internet connectivity, as well as people even being able to afford to pay for internet. And so if people who don't have those resources obviously have much more difficulty connecting with telehealth, and don't have that resource of their behavioral health therapist to be able to help them through some of that anxiety and depression that they were feeling. So I think that's a great point, and that's absolutely a structural factor that is a concern in this group. Anything else?
I like the question that's in the chat. Does anyone want to talk about?
I can't see the chat. Can you read it?
Yeah, it says, what did it mean for participants to have diabetes? I think they're onto something, just in terms of that attitudes, knowledge, skills, awareness kind of circle. It kind of helps us understand that their understanding of diabetes is different, right? Working in the colonias myself, some patients don't understand what it means not to have increased sugar. They think that having cinnamon instead can help their sugar, but that's not quite argon diabetes looks like. And it's also like an understanding question, right? And it kind of helps us to come from a place of empathy. So if someone who actually wrote the comment wants to jump on that and explain what they were thinking, I think that'd be really wonderful.
Yeah, some of the patients I have treated that have diabetes, they become very, very fearful of it.
Yeah.
They know people that have lost legs, they cannot see, they can. So just the fact that they have diabetes will start from a point of view of, I might be a failure.
Yeah, I think that's a really good question and a really good point. And I didn't talk about this as much in this presentation, but we did, part of the interview that we did with people was looking at the history of their illness. So prior to COVID-19, we asked about, how did they come to know that they had diabetes? We didn't ask about diagnosis. We tried to ask things in a way that would hopefully open it up for people to talk about multiple ways that they understand diabetes. And that came up, that fear came up a lot. So this is a community where there's a very high prevalence of diabetes. So most of the people that we interviewed had many family members who also had diabetes, and who had severe complications from diabetes. So people talked a lot about the fear and anxiety that they had around trying to control diabetes, and the ways that increased during COVID because they couldn't rely on their normal methods that they had developed over time, right? Or that they had seen their family members engage in the past to help control diabetes. They didn't have access to those resources or to those strategies necessarily during COVID. So that context is really important, that people had seen and experienced. People talked about trauma that they had experienced as a result of seeing family members have limbs amputated, lose their eyesight, and die, right, due to complications from diabetes. So that context of COVID-19 just really, for a lot of people, they talked about that being even more intense for them because of that history. So thanks for that question and comment.
I don't know if you can hear me. So having done a lot of telemedicine, both with the VA and as with urgent care, one of the things that I have noticed after the pandemic, people got accustomed to certain things, especially in rural parts of New Mexico. This learned expectation, like that people seem to be able to just call up for things like antibiotics or steroids, or and that's they get rather annoyed when they're not getting that instant gratification that comes along with telemedicine that they've grown accustomed to during the pandemic. where they should be seen by a person, they should be seen by a provider in person. And so I don't know, I don't see that. It hasn't worked out very well for a lot of folks in those rural parts. There are limitations, of course. Primary care is not available. Urgent care isn't available. Pharmacies aren't even available some days. So I don't really have good ways to try to deal with that aftermath. But this is something to throw in there.
Yeah. And, we did this study during COVID, so I didn't talk to people. I could probably go back and talk to them now and see what the situation, and that might be a good idea. Another study to go back and talk to people now to see kind of what the situation with telehealth is. But I think, there are a couple of things that I think are really important to think about with telehealth. Sure, one is that not everything can be done via telehealth, and that includes both for mental health as well as other physical health concerns, right, that people have. And you have the issue with even access to internet. And so some people never had the option of telehealth in rural communities, and instead were just doing without healthcare until clinics could open back up or could see them in person. But I didn't have, at least in this study, that I didn't hear, people didn't talk about, oh, this makes it so much easier, and, I don't want to go back to my doctor. Actually, people talked about how they were really grateful to have this opportunity during COVID because it allowed them to maintain some continuity of care. But people did actually often talk about how they were looking forward to being able to go back and see their physicians or their behavioral health providers in person. So I don't know what actually happened or what's happening right now, but that would be a good question to investigate further. And I think there may be, I'm seeing that I can only see the number of chats that have come up. I can't see the actual chat. So Dr. Mishra, I don't know if there's anything else in the chat.
No, the only other thing that came up in the chat is the link to sign in.
Oh, okay, perfect. So I think we have the last question I just wanted to hopefully that you all could think about, right? I'm not a psychiatrist or a psychologist. I'm a medical anthropologist. And so I'm truly trying to, my research is really trying to really elicit those experiences that people are having and talk about as best I can the way that people explain to me what was going on in their lives. And to try to use that structural competency framework in that context. But one of the other things I would be really interested to hear from you all is how you think this might be useful in your own practice in terms of thinking about the patients that you work with. So I'd love to hear people's thoughts about that question, but also I know we have about 10 minutes left, and I think we need to have some time for additional questions and answers. So I'm also happy to respond to any other questions that you all have. Dr. Mishra, did you have a comment?
I was leaving the space for others. I think Dr. Grace might.
Just wanted to say thank you for your work going out and talking and listening to these people. It's very easy for communities separated by rural or resources or other cultural factors to get kind of left behind or unheard. And it's cliche speaking as a psychiatrist, but words are powerful, and talking and hearing is important. And it's really good to hear these perspectives. So thank you.
Yeah, thank you. Thank you for being here too.
I know you're saying you might talk about what the focus group reactions were when you went back and presented the data. I'd be interested to hear that.
Yeah, sure. So, so when we went back to do the focus groups, we showed them And I should say we did focus groups in English and Spanish. The whole study was in English or Spanish, depending on what language the participant chose to participate in. And so we shared the model that I showed to you, as well as some of the findings from the quantitative analysis of the survey with people. And then we just asked them to respond to it. What resonated with them, what didn't resonate with their experience, what was different from their experience. Were there things on the model that maybe wasn't their own experience, but they'd seen other people experience? So those are the kinds of questions we were asking. And I would say in large part, people felt that it was a good model. I will say there were a couple of things that people pointed out that I think were really important. One is that, and we did make some modifications to the model because of that. One is that on the right side of the model, I think you all could see in the closer up version, there was a more free time component. And so there were a number of participants who said that they had more free time because they weren't having to travel to work. They weren't having to try to take public transportation anywhere if they were in Las Cruces. There's no public transportation in the Colonias, but if they had to travel to Las Cruces and try to use public transportation, and so they said they had more free time, and that allowed them to do things like cook and exercise. But we had one focus group where there were several women who had young children, school-age children, and they said, this is not true, right? This idea of having more free time, like it really depends on who you are. And they really wanted us to acknowledge that the additional childcare that especially mothers, they specifically pointed out mothers were having to take on during COVID actually significantly increased their stress and anxiety and led to some of the things that on the left side of the model that were leading to poor control of diabetes. And so that was one thing that came out that people hadn't really talked about in the interviews, but talked about in the focus groups, and pointed out that that was missing in our original model. And we did include it. I don't know if you all could see it, but we did include it in the second model. And then one other thing that people talked about in the focus groups that was about, and I won't go into details, but people they went into detail about how people started to rely more on like herbs that they could either grow or that they could have access to from neighbors, that were herbs and other plants that were used to treat diabetes. So like nopales was one thing people talked about. And then other kinds of herbs that they were using to try to maintain control of diabetes, and that they actually relied on those more during the pandemic. And that wasn't in our model. So people did bring up things like that. So it was actually really useful to go back to people and say, here's what we came up with, what do you think? So yeah, that's what we did. And does that help answer that?
Yes, thank you.
Sure. And Dr. Grace, did you have another question?
No, all good. Sorry, I just forgot to.
No, that's okay. I can actually stop sharing. I forgot that I could do that. Okay, so now I can see the chat. So I do see, maybe we have time for okay, pandemic is over. Are there suggestions about what participants could have done to make things better for them under the circumstances? So that, I think that's a good question. We didn't ask people directly about that. I think that, part of the right side of that model about what led to better control, maybe in there are sort of suggestions for maybe what people could have done. So I think, but I also think that it's important to consider the structural concerns, right? So we talked about telehealth, and like I said, the access to behavioral health was incredibly important for people. And so people who could connect to telehealth really, reported that they were much better able to control their chronic disease, right? Were much better able to control their diabetes because they were able to have those regular appointments with their behavioral health therapists. But, you know, people who didn't have internet or didn't have access, there was really no way for them to do that, right? And so, so I think rather than maybe thinking in that particular case, instead of thinking about what participants could have done, I think maybe the message there is, you know, what other options, safe options during this time could there be for behavioral health for people who don't maybe have access to internet? And what could we, you know, hopefully this doesn't happen again, but right, but if it happens again, what can we be ready with to be able to provide the care that people in these communities need, right? So I think that's kind of thinking more from that structural perspective, if that makes sense. Okay, yeah, group therapy is something other people tried. Yeah, it was, so one of the challenges that people, so in the communities where I was working, a lot of times people, those kinds of more social things or things with other people, like there were group exercise classes, there were diabetes education classes, those often happened at the community centers, and the community centers were closed during COVID. And so people really had a hard time accessing anything that could happen in a group. And then again, you know, people's isolation, whether self-imposed or maybe imposed by family members, really made it a challenge for people to participate in something like group therapy.
You know, Dr. Scott, I think we're almost going towards the end. Is there any other comments anyone has or any questions? Dr. Scott, thank you so much for coming today and giving us wonderful talk. We really appreciated it, especially outside of the world of psychiatry.
Yes, of course. I just wanted to say there are a couple of people direct message me about sharing some other resources or maybe connecting later. For some reason, I cannot type in the chat. Dr. Mishra, can you type my email address in the chat? Do you have it? Oh, I can't hear you.
I'll put it into the chat.
Okay, thank you. I appreciate it. And I would, in any other resources or information or any way that you all want to connect on this work or any other ideas for future work, please let me know. I hope to maintain, you know, a long-term connection and work in Southern New Mexico in rural communities. And I'm really happy to collaborate and work with anybody else who wants to do that work as well. And I'm sure I have a ton to learn from you all. So I would appreciate the connection.
Thank you so much, Dr. Scott. I put your email in the chat for anyone to have.
Thank you so much.
Thank you, everyone.
Bye.